Let me welcome the media here to this news conference called by the Dominica Hospitals Authority. This news conference is to inform the public on the operations of the board over the past year, successes and challenges, and to answer any other questions on the media about the Dominica-China Friendship Hospital. We want to say thank you in advance to the various media houses, DBS Radio, Kyrie FM, MO News, Vibes, GIS, Dominica News Online, Sun Newspaper, Chronicle, and to Carlisle John Baptist, who is a freelance journalist. Thank you, everybody, and to GIS as well, yes. With us today, we have the Deputy Chair of the Dominica Hospitals Authority, His Excellency, Mr. Eliud Williams. We also have with us the CEO, Dr. Dexter James, and also with us, Board Member, Director Cyril Robinson. There is a lot to inform the public on about the Dominica-China Friendship Hospital, and so without further ado, we want to welcome our first speaker he served as a youth leader, he served as a social worker, as a cooperative development officer in his early years. He was a management consultant, and he also served as managing director of ECTEL from 2004 to 2008. And so we invite our first speaker, former president of Dominica and deputy chair of the Dominica Hospitals Authority, His Excellency, Mr. Eliud Williams.
Thank you, Stephen Lee, and good morning to all. Let me first of all express pleasure at the fact that so many of you have accepted our invitation to be here. So to my fellow director, Dr. Cyril Robinson, welcome, and also in a special way, welcome to Dr. Dexter James. I am here filling the role, I hope I can do that adequately, of Mrs. Jennifer Astafan, who should be listening to us via Zoom. She is our chairperson, as I said, but unable to be here with us this morning because she has lost her voice, but not completely. So I have said to her to stay close, just in case we need her. There is also Dr. Ruby Blanc, the hospital medical director, who also will be online, but has issues with her voice. So I hope there's nothing here that is affecting the voice of our senior people. And sitting among the media, I hope that has nothing to do with their future ambitions. We have the Director of Engineering, Mrs. Nicole Laville. We also have Mrs. Owen, is it Thomas Henderson? Matthew, I'm changing that. Henderson. And I have no such problem with the other senior staffer here, no truncated name, and that is Miss Emmeline Matthew. So on to you again, the media. Thank you for coming and welcome. 1 year ago, the Dominica Hospitals Authority Act was passed by Parliament, and the Hospitals Authority Board of Directors was appointed as of 1st August 2021. Our mandate is to ensure that health facilities are administered in a manner to promote the welfare of patients and in keeping with best international practices. A critical requirement of our mandate is to operate in accordance with the highest standards of transparency, financial management, and accountability, and that you can find in Section 7.3 of the Hospitals Authority Act. As promised to you some time ago, and in keeping with the duty of accountability, we have come here again this morning to you, the public, to account on our activities over the last year. We promised that your concerns in relation to care and attention would always receive our consideration. It is our only secondary care facility, and we do, of course, offer some tertiary services. But importantly, we have promised to listen and to address the concerns. We've committed that every patient and their relatives would be treated with compassion and dignity. We know that it would take time to get attitudes to change, but nonetheless, it's been a journey that we have embarked upon to address these concerns brought to attention. In fact, all concerns brought to attention, and to investigate where necessary and to provide you with feedback. Today, we thank the public for being a partner with us on that journey as we improve the quality of our interaction with staff of the hospital and their relatives. Relatives can be assured, and patients, that there will be courteous treatment from our staff and in a respectful manner. I would be quick to say that we are aware we have not yet gotten there. We still have complaints about the manner in which some of our staff, and thankfully it's a minority of our staff, still treat the patients. But we recognize that training is required, and also a reward system will be put in place, but similarly, we will also have sanctions where staff have not followed the protocols required. And the sanctions, of course, will always be after due process. At present, as the only secondary care facility dedicated to provide services to the public, we commit once again today to deliver quality care using a cadre of medical specialists, both nationals from Dominica, because it said they're nationals, and technical services assistance personnel from China and from Cuba. These services today include, among others, that's why I say include, orthopedics, general surgery, ophthalmology, internal medicine, obstetrics and gynecology, and anesthesiology. The board, through its dedicated staff, is determined to maintain a waiting list which is of the minimum time. And therefore, we are all working to reduce the current waiting time to below 6 months in critical areas. Of course, emergency services always receive immediate attention. In an effort to set service standards at an international level, we have been collaborating with PAHO and Accreditation Canada towards the accreditation of our hospital. But this is a process that will take some time. We have, however, given ourselves a period of about 5 years to achieve this. And you may say, why accreditation? And that is because international accreditation means we will be delivering standards which are recognizable and which you can expect wherever you go once a hospital has been accredited. We have also engaged on a couple major projects. One is a 5-year strategic plan. The other is a pilot in telemedicine, and that's because we are hoping to take advantage of the presence of many Dominicans who have specialized in various areas of medicine who live in the diaspora. And telemedicine will give us the opportunity to access their services without them necessarily having to be present in Dominica. We are also working towards the setting of standards in key service areas. And in addition, we are preparing for digital transformation under the World Bank project, which is being executed by the government of Dominica through the Ministry of Public Works and the digital economy. We are nearing completion of the new hospital buildings, a gift from China valued at nearly $50 million US. Yet we are well aware that buildings by themselves will not be enough to satisfy the policy objectives of the government and the Dominica Hospitals Authority. The hospitals, and I say hospitals because it will be Marigot and Portsmouth as well, will require compassionate medical, nursing, and other staff who will treat patients with dignity. Over the next couple months, we expect that the new inpatient buildings will take our patient capacity from a current number of 219 to 318. Therefore, the situation we now face with overcrowding at the Accident and Emergency Department while these patients await a turn to get a bed on the wards will be something of the past. We recognize as well that there are the wider issues brought about by CNCDs and the need, of course, to further strengthen our primary healthcare services. So, what else can I say to you? We have embarked on the journey to deliver quality care at this hospital, and so this is really what we are seeking to do. We're also getting ready for imminent commissioning of the new Marigot state-of-the-art hospital, and we expect an announcement will be made shortly. We have also advertised for a manager, and we expect towards the end of the first quarter of the financial year 2022-2023, we will be ready to operate Marigot. I thank you.
Okay, we want to say thanks to the Deputy Chair of the Dominica Hospitals Authority, Mr. Eliud Williams. At this point, we call on Dr. Dexter James, who is the CEO of the Dominica China Friendship Hospital, to deliver his address.
Thank you very much. His Excellency, Deputy Chair of the Dominica Hospitals Authority, Board Member Dr. Robinson, my chairperson who is not here with us today but is viewing this ceremony by virtually. Pleasant good morning to the media. My task is really to share with you our achievements over the last year, highlight the challenges, and also bring to the fore the plans and programs for 22-23, year 2022-2023. Just by way of information, this is a profile of our board. It is chaired by Mrs. Jennifer Asafan, and His Excellency Eliud Williams is our Deputy Chair, and other members, as you see on the slide. During the year, the board has embarked on a number of key policy matters, including we had to establish our board committees in accordance with the Act, the Finance and Audit Committee, Human Resources Committee, the Clinical Committee, and they really give life to what happens here at the hospital. The board embarked on a strategic planning session, April 21st to 23rd, to essentially begin to focus the organization and the authority in the long term. We develop our admitting privileges regulations, which will see persons in the private sector being able to bring patients to the hospital and use our facilities. These regulations haven't been passed as yet, and once they pass, you will hear a lot more about it going forward. As His Excellency raised earlier on, we prepared ourselves for the phased commissioning of the Marigot Hospital. And I say phased because it is a process that we have to embark on as resources come our way. We've submitted the fees for our MRI services and fees for use of the operating theaters. All those are with the Ministry and Cabinet awaiting approval. We've recently finalized most of our employment contracts with medical officers, including specialists. As of today, there are only one outstanding, and the board is attending to that as we speak. Key achievements, just to set the scene, is that we currently provide a very wide and broad menu of services. Today, your Dominica China Friendship Hospital provides general surgery, pediatrics, ONG, internal medicine, radiology, psychiatry, oncology, dermatology, accident and emergency services, anesthesia, ICU, and physiotherapy. But the menu of services doesn't stop there. You have a number of subspecialty services that we provide here at the hospital. ENT, ophthalmology, urology, neonatology, gastroenterology, nephrology, cardiology, and infectious diseases. I can tell you that the number of referrals that we have been making over the last year have reduced. I think the last quarter we only had about 15 referrals at a cost of $1.3 million. And these referrals are mainly for radiotherapy, major urology, and patients requiring invasive cardiology procedures. So a lot of the pathology and disease profile that we have here in Dominica, we pretty much could handle it here at the Dominica China Friendship Hospital. So that reduces the amount of off-island care that is currently provided, that hitherto was provided in other countries. Major achievements, we commissioned the MRI services. We one of 2 MRIs, public service MRIs in the OECS territory, and we really are proud of that as well. We've commissioned the high-intensity focused ultrasound unit for treating patients with various types of cancers, breast cancer, cervical cancer. We're happy about this commissioning. We're the only facility in this part of the world that has such a facility in its public health facilities. We have been able to successfully manage COVID here at the hospital to keep this patient, the facility safe for staff, patients, and visitors. We've commissioned the Brenda Stratford Foundation Eye Care Center in a new state-of-the-art facilities that could now provide a more comprehensive and robust eye care solution for the population. We finalized the MOU between ourselves, the Government of Dominica, and the World Pediatric Project for providing tertiary care services to children between the ages of 3 and 21 for basic, for tertiary care services that are not currently available here at the hospital. The second bullet here, while it may seem pretty much routine, but when we inherited this system, a number of our farmers, for instance, were getting paid late. Today, every single farmer who provides supplies here at the hospital, they get paid 1 week after the month end. There's no issue anymore. They understand that once they submit their invoices in good time, they all get paid. And we're proud about that because the farmers play a very important role in supporting us here at the hospital. And many times, what we've inherited is that farmers have to wait sometimes 2 and 3 months before they're able to get payment. So this is a major achievement for us, for our farmers. And likewise, payments of salaries to staff. We inherited a situation where staff waiting for appointments were getting paid late or not at all, sometimes 2 or 3 months. Now, that is a thing of the past. It may sound very simple, but where persons have worked, it is the board's view that persons must get paid and paid on time. Another achievement is that we've centralized the waiting list. We can't manage something that we don't know about. So we took a decision that all the waiting lists that are now held, and this is the public waiting list by all our specialists, must be brought into one central area so we're able to manage the list a lot better. Linked to that is that we've established a theater users committee, a committee that is self-governing to ensure that the public's interest takes precedent over private endeavor. And I'll show you a slide why we had to take that decision. The Theatre Users Committee will ensure that the theatres are safe to use. It will make sure we have adequate supplies. Whenever safety is threatened, they will advise us. And of course, we look at the public-private mix. As you know, we've launched our cataract initiative, which is ongoing. We have identified close to 180 patients who are waiting for cataracts. We've asked persons who were here with us before and have had to go privately to come back to us. And we offer no apology for it. All right? This is the time where the public's interests must be satisfied and served. So we've had a number of persons coming back to us. We've done their measurements, and they will be scheduled for surgery. This is a project that has to take root until such time that we're able to now open back the facility for private work. Of course, all emergencies will be given preference, whether public or private. But from where I sit, and the instructions I have from the board, is that we have to direct our attention towards dealing with the public patients who've been waiting for months to get the cataract surgeries done. We have 2 ophthalmologists on staff at this point in time, and we're working with them to make sure they have the supplies and that they could then, process these patients based on urgencies and necessities. We've introduced the minor cases unit at the Accident and Emergency Department. That department sees about 14,500 patients a year. of which close to 80% of them are for non-emergency care. So we put in place a minor cases unit right within the department to fast-track the non-emergency care of those patients who are just waiting for diagnostics. Many of you within the last 2 or 3 months would have gone to our emergency department would realize there's no waiting time anymore for non-urgent care. None whatsoever. If you go there for a non-emergency condition, you're seen, triaged, and treated and dispensed with a measure of urgency. This is a feature that we're extremely proud of. We have other problems in A&E, but I can tell you that with respect to treating with non-urgent care, we've had some successes where that is concerned. This gives you a sense of where we are in terms of utilization on the key installations that we've made. Since commissioning the MRI in November last year, we did the training of the staff. We've done 297 studies, broken down as follows. 297 studies in less than 6 months. These are persons who hitherto would have spent $3,000 to $4,000 going to Barbados or Trinidad or Guyana to get these studies done. And they're getting those studies done right here in Dominica. 297 patients. So when we talk about access, this really is the real essence of access, in that care can be provided right here at the Dominica China Friendship Hospital. Similar situation with the HIFU, high intensity focused ultrasound. We launched that in February, March this year. We've done 14 cases, and this is a non-invasive procedure for dealing with various types of cancers. Cancers in women, fibroids, breast cancers, soft tissue carcinoma. Again, in a non-invasive way. The HIFU system is the only one in the English-speaking Caribbean. There's none other. So we intend to leverage this capacity to be able to bring patients here and have them benefit from the procedures. The procedure is about 45 minutes, maximum an hour, non-invasive. And then we follow you up 3-4 months down the road to see if there's any shrinkage in the tumor. This is going to tremendously revolutionize women care, particularly those women who present with fibroids, and the only alternative that is provided to them is a radical removing lost my trend there. The uterus, right? So this is a non-invasive procedure that many women could benefit from, and we ask you to see your gynecologist early, so we could decide whether you are a prime candidate for it. If we catch you late, then we have to go the very invasive way to treat. I raised earlier on the question of the minor cases unit. When we came on board, there was this situation where a lot of the cases that were done in this public facility were private cases. I'm sure everybody is aware of that. Our board directed us to make the changes to reverse those gains. And you would see from October last year to June this year, if you look at the trending, you would see in October, we were doing 60% in private cases. 60% of the surgeries done at the Dominica China Friendship Hospital were private cases. Today, if you look at May, June, you would see the reversal. Only 20%, 20-25% are private cases. And even if you say May and June are outliers, if you look between, say, November and April, November 2021 and April 2022, you would see it levels off at around 40-45%. And that's the kind of margin we really want to do. The public's interest must be served first in a public facility. So this is where we've made some major changes, and this is for general surgery. The same trend we've seen in obstetrics and gynae. They were 60% in October. Today, they're pretty much petering off around 50-55%. Gynae is the area where we have to do some more work to bring that in line with established practices and in accordance with the directives set for us by the board. Major installations, as you know, we His Excellency raised earlier on, we've expended close to $50 million. The government has expended close to $50 million in recapitalizing this plant. We now have a full-fledged digital X-ray. We now have the high-intensity focused ultrasound or CT scan, the MRI, which has been commissioned in November last year. This is our state-of-the-art eye clinic or operating theaters. As you know, we have 7 operating theaters on this campus. 4 main, 1 in A&E, obstetrics and gynae and eyes. So there should be absolutely no reason why, as His Excellency raised earlier on, we cannot bring waiting lists for all types of surgery within 6 months. I would say within 3 to 6 months. In the case of eyes, because it's ambulatory, there's absolutely no reason why we can't bring eye care, particularly for cataracts, which is 65% of the work that ophthalmologists perform within a 3-month period. But we got to work at it, and we have to work at it working in conjunction with our specialists. This is our 8-bedded ICU department. Inpatient construction, as indicated, we're moving towards completing the 2 inpatient buildings. Each will be about 30 beds. They're in semi-private and private rooms. This gives you a configuration of the facility. I think when Dominicans see the facility, they will indeed be proud that you have not only the most modern configuration of a hospital, but you would see the facilities there that are enabling to make patient care a lot more comfortable for all patients. There's now a central area patient dining area for patients. No longer patients who are ambulant will have to eat at the bedside. They go to a central area and they will have their meals. We've made provisions for doctors and nurses' offices. There's a patient waiting area as well. So very shortly we'll invite the media and others to come and take a walk through and see the facility so that by the time we commission, it wouldn't be anything new to all of us. This is the bed distribution where we're moving from and to. We're moving from 219 beds to 318 beds. This may look as a big jump, over 50%. But if we do not begin to arrest the problems that we have at the primary care level, in 5 years' time, we need to double this. This is a very, very serious problem for us. The big problem we have now is that for the last 6 to 8 weeks, our observation rooms at the accident and emergency department has been filled. We can't find beds. If you go to our medical wards, what do you see? The over 65s with the uncontrolled diabetes, uncontrolled hypertensive, patient presenting with cardiac problems. We cannot move those patients or fast enough to move the patients from A&E onto those beds. We know if we don't fix this primary care problem, we will be in a lot of trouble. So I'm sending the message out that the primary care operators in the country needs to start to really look at what we're providing out there. It is not about bringing you here and housing you on diet, bed rest, medication. Nothing more. Diet, bed rest, medication until your condition stabilizes, and then we discharge you. And then you come back in as a revolving door into A&E. We got to fix that. It's about prevention. It's about taking responsibility for your care. So this is the expansion that will take place. It will provide an ease to the problems we have in A&E. But it's not the solution. It's a temporary fix until and unless we begin to resolve the problem at the primary care level. The Marigot Hospital is completed in terms of its infrastructure. Steps are currently being taken to install various pieces of equipment. And we believe towards the last quarter of this year, His Excellency said the first quarter, sir?
No, of the financial year.
The financial year.
So that's July to September.
July to September, we believe that we will be ready to commission it on a phased basis. We have to now finalize the discussions with the cabinet. The board has submitted this paper, and we'll share with you what the phased commissioning will be. But I hasten to add, it would be nothing less than what you had before. It will be nothing less than what you had before in this facility. So the ground floor, you have an accident emergency department with the X-ray facilities. emergency access for 3 delivery rooms. So they're actually built-in rooms, which is fairly modern. You don't find built-in facilities in most of our hospitals. This one will have 3 built-in facilities where patients can go into a room and deliver right in their own private setting. We'll have 2 dental chairs, two dialysis chairs. So a lot of the patients who come to the hospital here for dialysis care, who live in and around the north and east areas, we will then have them go to receive the care at that facility. Of course, we'll have the diagnostics, lab, dispensing, and other facilities in that. It's a full-fledged facility, 50 beds. This is not a community hospital. This is a secondary care facility. I want us to recognize that. This is a secondary care facility. Having to keep the environment safe and had to repurpose buildings, repurpose facilities for COVID. I raised the issue about the unnecessary admissions to A&E. The challenges with bed management. So if we challenge with bed management, we now have to cancel elective surgeries because it is the only way we're able to find beds on the wards. If we for us to move patients from A&E to the wards. We had challenges in sustaining our oxygen. There was a time we were only producing one bottle of oxygen per hour. 1 bottle of oxygen per hour in the height of COVID, 24 bottles a day. I want to thank Mrs. Lavin, our Director of Engineering Services, for staying the course and making sure that we had 24 hours. The plant was running 24 hours to give us 24 bottles. Today, with her effort and the effort of philanthropic support, we're now producing 60 bottles per day. The plant has now been restored to a situation now where we could sustain the oxygen production here at the hospital and support our primary care network. This is, I would say, a short-term, medium fix. Our long-term solution is to purchase another plant for redundancy, which will reduce the amount of outsourcing that we do. So our commitments for 2022 is we'll continue to provide the psychosocial support for many of our patients who face traumatic situations. All our doctors are not good at breaking bad news. We're not good at breaking bad news. So we have to find a way of providing support for patients to move them through that stage of denial, anger, depression, and acceptance of their health condition. And so this is something this is an area of our operation that has been missing, the psychosocial support to bring patients to an understanding of their care situation so that they're comfortable in spirit and mind to be able to receive the care to be provided to them. Patient advocacy support group is another area we're seeking to develop. We're heartened by the level of feedback that we get from our customer, from our patients, on any and all matters, the good, the bad, and the ugly. We get good commendations, and we got areas that we need to improve. Those areas that we need to improve have served us well in that it allows us to find out what has gone wrong and take the corrective action. Look, I'm saying today, let us not discuss the business of health on social media. That's not the place to do it, because any one of us could be casualty of war. Let us be advocate for a better healthcare system at the end of the day. Give us a chance. If there are problems, there's the complaints route. We have a quality department, and it is a very objective process that we go through. Where we're wrong, we learn from it. But we give the population the comfort that feel comfortable that you could report your complaints, if not to the quality manager, make the complaints to my office. And I guarantee you we'll follow up on it, do the investigations, and then we provide the feedback to yourself. But that notwithstanding, we feel that we should set a patient advocacy group to be the mouthpiece of those who feel that they're disempowered. We're partnering with China in setting up a cardiovascular imaging center to as a state-of-the-art to produce echocardiographs, heart MRIs for the heart, and perhaps more importantly, congenital heart diseases in children. This will be the first in the region. This would put us at a next level in terms of child care. We're seeking to develop some centers of excellence, eye and imaging services, which we believe could be brought to that stage. We're seeking to finalize a memorandum of understanding between ourselves and the University Hospital in Martinique for tertiary care that cannot be provided here in Dominica. And finally, we would seek to develop capacity here in collaboration with the Dominica State College in putting in place a number of programs that will help strengthen our operations. So scrub technicians, customer service training, training of our orderlies, and we're working through with Ross University in launching a program on advanced cardiac life support and basic life support training for selected categories of staff. So that is the end of my presentation. I look forward to any questions you may want to ask at the end of the session. Thank you very much.
And of course, I want to thank Dr. James for this thorough and in-depth explanation of some of the major achievements and challenges here at Dominica China Friendship Hospital. At this time, we would like to invite to the podium Director, one of the board members of the Dominica Hospitals Authority. We now invite to the podium Dr. Cyril Robinson.
Thank you very much. I'd like to acknowledge the presence of His Excellency, our Deputy Chair, Dr. Dexter James, who is our CEO, the board members who are following virtually, and of course, our heads of department and the media. The Dominica Hospital Authority, when it was put into effect by an act, was set up to oversee the operations of hospitals in Dominica. At present, the Dominica China Friendship Hospital is our primary, well, it's our secondary facility, but the foremost of those. And as Dr. James has explained, soon to come online will be the Margaret Hospital. The DHA board promotes patient-centered care. We understand, we get it. We understand patients are important. We know, irrespective of the quality and the magnificence of the plant, the important part at a hospital is how you deliver care to the patients. We get that. We really do. We understand as well patients attend the hospital at a low point. People come to the hospital not because they want to come on a holiday, but because they are at a low point, emotionally, physically, psychologically, and they come to get those needs attended to. The role of the hospital and its staff is to attend to those needs in the best way possible. We get that, okay? The board gets that. We want to do it. We understand as well that hasn't always been the case. But going forward, we want to correct all of those things. We want to make the utmost effort that when you come to the hospital, your needs are met in a way that satisfies you. We acknowledge the limitations of at present. We know things are not perfect. But the role of the staff at the hospital, everybody, clinical staff, ancillary staff, maintenance, the security, people who work at the gate. The role of all of these people is to embrace the challenge, to embrace the opportunity, to make things better. We don't want to concentrate on how bad things were in the past, however good they were in the past. We want to improve from this point forward. And that is the role of the board. That is the role of the staff at the hospital. We want the best possible outcomes for the patient. And we know you want it too. Resources are not unlimited. In the US, which is the richest country in the world, there are still limitations on who can get health care and the type of health care they can get. We understand that. We understand resources must be provided to staff. The plant has to be of good quality so that good outcomes can be met. However, a lack of resource in any part must never be an excuse for substandard care. Our remit here is to provide excellent care to everyone. And when patients present at the hospital, they must meet an institution that treats them with dignity. I mean, we get this recurring complaint that people do not feel they are treated with the dignity that they deserve, or that their relatives are not given the care that they deserve. We want our staff to exhibit empathy to the patients. We want people who come here to feel that they are not in your way. They come here for care that you want to deliver to them, and it has to be of a good standard. We want our response to be professional. We want it to be considerate. Those are the things we want. The board is passionate about that. And we can do all of those things. Every member of staff is a cog in the machine, and every member is important. Everyone who a patient comes into contact with at the hospital has to feel that their role is important in the delivery of health care. It may seem unimportant to, let's say, the receptionist, but that is maybe the first point of contact that someone has with the hospital. That's the first impression they make. The DHA wants to take hospitals in a direction that promotes confidence in the services, reliability in the delivery, and value for the money that is spent. We want to become a center of excellence. We want people to come here from overseas for treatment. We want that. We understand it will take some work. However, becoming a center of excellence requires everyone to be engaged totally. Everyone who is involved in providing that service has to feel that they make a difference, that they're important to deliver of that service. And that is what the DHA wants. This hospital is not a private institution. People ask me all the time about the hospital becoming private. This is not a private hospital. This is a hospital that belongs to all of us. It is funded by the government. It is funded by you, the people who come to the hospital for the services. The staff are paid by the government. This is a public facility. It will remain a public facility. And we want the public to understand that totally. Going forward, there are some changes that we anticipate will be made. There used to be private rooms at the hospital for all kinds of reasons. Visiting dignitaries, people who want or require a greater degree of privacy. There are all kinds of reasons why people want to have their privacy when you're at a low ebb. And those things will come. But essentially, this is not a private hospital. This is a public facility funded by public money for everyone. And this is the way it will remain. This facility, under the stewardship of the board, and with the involvement, total involvement of its staff, wants to go forward in a direction that sees the public participating. The CEO has addressed the issue of complaints. We don't want complaints to be just, I went to the hospital and blah, 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 this isn't good. We know those things happen. We want you to be involved. We want you to tell us how we can get better, not just complain about what didn't happen. We also want you to compliment the staff when things go well, because we have a lot of staff who do things properly. We have staff who are excellent at what they do, and we know that. In every institution, there will be people who do not do the job they're supposed to do, or they just turn up. And we all know that. The issue is not to concentrate on only the things that don't go well. We want to reward and compliment people who do things properly. So feel free, when you write into the hospital, if there's somebody who has done a job well, tell us. We want to know. Change is difficult, but change is important. The hospital has gone from being under the administration of the Ministry of Health to now becoming a quasi-independent authority institution. That change takes time. that change is slow. It may seem glacial at times. Some things we can do quickly, other things we can't. We ask you to bear with us. We ask you to be tolerant. It doesn't mean you have to tolerate everything, but we have to understand that some things take time, and the board is actively working to make the things that are not well, to make them better. The things that are good, we want to be best. The importance here is the intention to improve. And we encourage you, the public, and we encourage the staff to work with us on that. It's a learning process. It involves cooperation between us and the public. But we are confident that it will happen. We get that patients are important. And we want you to understand that we are working towards making any experience at the hospital one that I won't say you will enjoy, because it's sick people who come here, but we want it to be an experience that you do not have to complain about. And if you work with us, the public, on that, help us to help you, I am sure we'll get a good outcome. Thank you very much.
And I want to say thanks to board member, Dr. Cyril Robinson. I hear the words turning the negatives into positives, and patience and cooperation from everyone. At this time, we invite the media to ask questions, and we know that the media have a number of questions to ask the head table. So it's your turn now to ask questions. Yes, can I? And maybe you can come to the head, come to the podium, so the public can hear your questions. Yeah.
Okay.
Yeah.
Cyril John Baptist, Nature Isle News. Over the past time, I've been hearing people complaining about a pathologist. I know of an incident where someone came from Canada to bury a loved one and had to leave without the autopsy being done. From the information I have, we don't have a pathologist from Dominica. So almost every time, probably have to get one from Antigua or wherever. What are you guys doing to get a pathologist? Because you're having autopsy reports on a Tuesday and a Thursday, and this is causing a lot of stress to people of the country. What is being done to help people with that situation? If loved ones and an autopsy has to be done, what is being done at this point in time?
Well, that's a good question. As you know, the pathologist who's here at the hospital is one who has been assigned under the Cuban Technical Assistance Incorporation Program. The pathologist went back, and there was a hiccup with respect to the replacement. So what we had to do is that we engaged a pathologist out of Barbados who came in on a fortnightly basis to clear up all the autopsies, any slides to be read, any reports to be done. That situation has been corrected. We now have a pathologist on staff about almost 6 to 8 weeks now. So that situation has remedied itself over time. But it's a challenge we had at the time. And as I said, we brought in a specialist on a fortnightly basis to be able to address it.
But if I may just quickly follow up, because we've been going through for years a Cuban pathologist. I go to the court all the time. Then you hear that the pathologist will be leaving state, so that the pathologist report must be taken. When you get to the High Court, there's no pathologist. And almost every time is a Cuban. From your end, what are you all doing probably to train someone to assist? I mean, you know, because I know of someone who's right now in the media who was trying, who did the white coat and was trying to get themselves into that realm. What are you guys doing to assist someone in terms of getting trained, qualified to be a Dominican pathologist? We had Dr. Peter Bellot and so on and so on, Dr. Watty. We no longer have them for years now. We keep bringing in people back and forth from outside of Dominica.
All right, so to answer the question, the first issue is interest. You have to have persons who want to do pathology. I don't control the scholarship side, but they have to have persons who want to do pathology. I would tell you, sir, pathology is not one of the sexy areas in medicine. So you have to have a Dominican who has that interest to do pathology. Our board is, as there is the issue of pathology, is taking a comprehensive look at the health needs for hospital services. There are a lot of services we do not now have. We've identified persons who are studying now, which will address that problem going forward. So for instance, we have no vascular surgeon. So if there's somebody who requires dialysis and we have to insert an access point, we don't have any vascular surgeon. By next year, December, we'll actually have a vascular surgeon on staff. So we have to take a comprehensive look at where are the gaps in services that we do not now have, and then we'll then make the requisite overtures to have those filled. But you would admit that from the presentation we've made, Dominica has a number of subspecialist areas that countries that have twice our population and 3 times our populations don't have. And I want you to understand that it is not all the services that we can have. Let me give you an example, quickly. It is nice to say we should have a neurosurgeon on staff, but do you bring a neurosurgeon on staff to do 1 procedure every 2 months? He will be skilled. So we have to find a way now of addressing it by saying, we have the ICU, we'll stabilize patients who require neurosurgical consults, and then we fly in a neurosurgeon to operate on them. It is not all the areas that you would need to have a specialist in a small country that is resource-strapped. The issue really of pathology you raise. Telepathology is what could we use? You may not know, sir, we don't have a radiologist on staff today. But we have 2 Dominicans that we now send images across the electronically. They read and report on it and send back the studies to us. So telemedicine solutions is one of the technologies we will embrace to provide services to Dominicans where it is not cost effective to have the specialists on site.
Okay. Let me just say that it's more of an announcement, really. No, not an announcement. You still want me to speak here? No, I'm aware that Dr. James has been very comprehensive, and you would note as well on the program we were to have Dr. Blanc. Dr. James has covered most of the items that Dr. Blanc would have, so that's why we went straight to Dr. Robinson. What I would like to suggest is that if you can keep the questions short, and if we can try to get as many, or maybe a cross-section, maybe from 5 different people, so that because we wanted 90 minutes, but the radio station whose main hostess only gave us an hour, so you need to respect that. Maybe we can squeeze 5 or 10 minutes more, but that's it. So maybe 2 or 3 other questions, and we'll try from our end to be very short.
Good morning, all. I'll be very quick. Doc, you mentioned, Dr. Dexter James, you mentioned we have 2 dialysis chairs. Any efforts been made to have more? Because I noticed we have an increasing number of patients, dialysis patients in Dominica. And anything being done to increase the service, prompt service at the A&E departments? I had an experience, brought in an old woman, and there was another case where a woman was just fainting at that department, at the door. Anything being done to get somebody in that area, a nurse, and maybe the security to better understand the urgency of certain people who come in? Luckily, Dr. McIntyre came in and just assisted us. Yeah?
Let me say it's a different approach. Perhaps we can take about 5 questions, so that, I will just do
it's unfortunate because people send in questions, people listening, and they send in questions all across.
Yes. Well, we asked for 90 minutes because
people want, they have questions.
I don't think you have any control over master control, but we did ask for 90, we're only able to do. So we'll come back. That's what we can promise you. We can come back perhaps in another couple of weeks.
Okay, there are presently reports that a contract has been put in place which prohibits consultant specialists as well as medical doctors from engaging in private service. That's those that are employed of the government of Dominica. Can you just inform us what is, if it is true that is the case, if it is true, what is the thinking behind this decision? Also, my question is directed at Dr. James. We're hearing that effective September 1st, this will be your final day as the CEO. Can you just confirm such reports if it's true? And what follow-up or replacement plans does the board currently have in place to ensure we have a smooth transition if Dr. James leaves, to ensure we see a CEO? Thank you very much.
Go for this.
No, anybody else? Can I ask the question?
Okay. Yes.
I just wanted to. Yes. I heard Steve's complaint the A&E. I have had two personal experiences, and I will just share that quickly. I brought in my grandson at the hospital, and the response that I got from one doctor was not very good. I don't want to say much about that. But then I had another personal experience where I collapsed in church, and the response that I got in here was tremendous. I mean, I can tell you, by the time I arrived here, the work by the doctors to really revive me and the nurses, it was really very, very good. I said that on a program. So I want to publicly thank them. It was a good experience. So some of us, we've had bad experiences. Some of us, we've had some, but the nurses and the doctors, they did a fantastic job. The question though also is, we've had nurses leaving the country in droves. Yes, we've had a number of wards being filled. One nurse said to me that she's been working over and over and she's not even sure what else can she do. Day before yesterday, I came to the hospital. I met a particular doctor who was on shift from 8 in the morning, and he told me he's working a double shift. I mean, this is not good. No rest. Nurses are leaving. Some are asking, how are we going to address that situation? Is it a pay concern or is it a lack of, I'm not really sure. See, how are we going to address the situation? Doctors and nurses working back to back to back. That is not helping the situation.
Let's go quickly. Question of dialysis service. Today we have 31 patients who are on hemodialysis. The move to set up the chairs in the Marigot Hospital is to decentralize services and to be able to provide improved access for persons who live in and around the particular area. The A&E department all over the world has a love-hate relationship. This is not unique to us. In Canada, I was speaking to a friend of mine, 41 patients were waiting in A&E for beds, can't get beds. The patients who present in a life-threatening circumstances in an emergency room, as the previous speaker raised, you get care instant. The problem is that those patients who present for non-emergency care are the ones that stay inordinately 3 and 4 hours, and they're the ones who really give us the negative goodwill. As I mentioned earlier on, we put in place a fast-track system. We've set in place a minor cases unit that will fast-track in non-emergency care. And I can tell you over the last 5 months, there's never a time you would go in the waiting area outside A&E, not in the main entrance, outside A&E, and you will see patients waiting there for non-emergency care. So I take the point that we have a lot more to do. It's still early days. We're not trying to absolve the primary care from its responsibility for non-urgent care. But if they present our doorsteps, we have to find a way of managing them, and we manage them. I want to thank Mr. John Baptiste for the balanced view. This is all we want. We want a balanced view, the good, the bad, and the ugly. Most times we hear the bad and the ugly. We want a balanced view about how we operate at the hospital. The issue of nurses attrition. Yes, there is attrition at the hospital. I can tell you we don't have more than about, I would say less than 10 over the last year who have left. But at the same time, what we've done is that a lot of the nurse interns who ordinarily were sitting and waiting for results. We brought on close to 10 to 12 of them over the last 7 months. A number of graduates who've recently passed the regional exams. Our board has given the approval to bring on an additional 10. The problems we're having is that there's a high level of absenteeism among our nurses. And this is really the challenge. So the attrition is less of an issue. The absenteeism is particularly a problem. Because if you look at our cadre of nurses and nursing assistants, we really don't have too much of an acute problem. But it's the high level of absenteeism. And we have to find out the root cause. Why as staff, the absenteeism rate is so high. And if we're able to fix that, I think we'll be able to have a more sustainable nursing program here at the hospital. The issue of my resignation is above my head, so...
Just before Mr. Williams come, we're going to continue until about 11. I was given the okay by my program director that we can continue until 11. Kyrie FM is continuing on Facebook. Okay, yeah, until 11, yes. So, yeah. Okay, the issue of Dr. James' resignation, you'll be able to answer that?
Wonderful, there will be questions. Okay, so two things. The first one, what made your house? Freelance. Oh, freelance, wonderful. Yes, we know there was some noises in certain communication channels out there about contracts, yeah? Something about contracts. What has happened is this. A number of staff, most of the staff working at the hospital, were staff of the Ministry of Health. So a year ago, when the authority was established, these staff were transferred on secondment to the hospital. So they came with their public service agreements, contracts, conditions. But at any given time, the hospital has always had other people who are on contracts. So they were not people appointed by the Public Service Commission. Private practice has always happened. People have always had doctors the opportunity to do private practice. What you don't hear a lot about is that these doctors, given permission to do private practice, have had conditions attached to their private practice. And let me give you one very clear example. In one case, a particular doctor was given permission to do private practice from 4 p.m. to 8 p.m. 3 days a week. That doctor is also a surgeon. And we speak of surgeons in general terms. They are general surgeons, ophthalmologists, obs and gynae, urology, people who use the knife and things to cut. But you had permission from 4 p.m. to 8 p.m., 3 days a week. But these same surgeons perform surgeries from 8 in the morning on private patients in the public hospital. We don't hear anything about that. Is it that they are doing these surgeries on private patients outside of the terms approved for them? So that's a question sometimes that should also be asked. So at no time has the board said a doctor who had been doing private practice will not. What the board has said and will continue to say is that there will be conditions attached, because by law, we as a board must perform within conditions of transparency, accountability, and good financial management. So when some of these questions arise, you must ask, has anybody on the board or has the board denied you the opportunity to do private practice at the public hospital in any way that you were used to and you're not? But people don't like having conditions attached to what they do. But conditions will be attached because it is in the public's best interest.
I'm sorry, but can you just highlight some of the conditions for us?
Oh, okay. Yeah. So we're saying, which Dr. James pointed out, that we expect the focus should be on the public patient. So if you're doing 30 surgeries, it should be 60% public, 6 3 is 18, and 12 maybe private. At no time have we seen anything close to that. What we get is maybe 30 surgeries and 28 private. The board cannot allow that to continue. We are saying over and over, doctors must be given the opportunity to do private practice to enhance their earnings, because the earnings in Dominica may be satisfactory, but they're not the greatest. I think we all know that. So yes, I could give you an example. We could give you many more without any name calling. Right. And the second question is that, yes, Dr. James has been here, but he came first as a consultant, short-term consultant, and then he was recruited. And those of you who would have seen the advertisements, the vacancy announcements for the CEO, would recognize that we were looking for somebody highly trained, highly qualified, highly experienced. We recruited Dr. James because he met the requirements and the specifications. He has, however, told us that he wishes to return home before the actual end of his contract. So normally he would have been here till, let's say, to be precise, he started on 11th of January last year. It would be 10th of January next year, but he must get vacation. So he could have been leaving here as early as end of October. But he said he wishes to go back home a bit earlier, so he'll probably be with us until end of September. So again, the noises you hear in the communication channels, not all of it is true, or certainly not all of it is accurate.
And presently, replacement plan.
Oh, yeah. Transparency again. So we will advertise the position and look for someone else. Because it's a private choice, a personal choice. He wants to leave. I mean, we've always said Dominica is such a great place, a beautiful place. He says yes, but there are some other commitments, so he wishes to go. But yes, you can expect to see a vacancy announcement fairly soon. Replacement. Yeah? Any more questions? Come here. I want it recorded.
Okay, so this is a question from MO News, our online viewers. Kudos to our online viewers. So, kudos to you all on the efforts being made towards the Marigot Hospital and the implementation of new services, etc. However, with efforts being made to decentralize hospital services such as dialysis, are efforts being made to implement these services at Portsmouth. And the particular viewer highlighted that, for example, dialysis and other services can be particularly draining for patients, so Portsmouth might be a closer traveling distance as well for a lot of people in our population. As well, it would also reduce the strain on the Marigot Hospital as well as Dominica China Friendship Hospital. So yeah, are efforts being made, or can we? Yeah. Okay, perfect.
In light of we're hearing of the shortage, which you all announced, or some of the medical equipments at the hospital. So I'd like to find out how does the hospital generate some of its revenue? And of course, a question that was asked, are there any plans to increase some of the fees that are at the hospital? Another question is that I know last year a campaign was launched to get our healthcare workers vaccinated. And while it may look like we are not out of the woods as it pertains to the COVID-19 pandemic. Can you give us an update as to how the statistics is looking, if we're seeing an increase in the vaccination rate, or if that still remains an issue? I know under complaining of some of the issues that were happening at the hospital, while we have people reporting these things on social media, what the board is saying is that enough people are not coming to the hospital and the quality department. Thus far, for the years since that appeal was made, have you seen an increase in the number of complaints being documented to the hospital in the proper manner?
The hospital does look good, but before that, we had an issue with the birds. And I'm seeing the birds, they're becoming a nuisance again. What do you all intend to do to deal with the birds that all over the place, really doing whatever they're doing and letting go everything on people and really messing up the entire space at the hospital. No, this is serious. The other concern is that as it relates to staffing, you did say that, yes, attrition, etc., etc. But in terms of the salaries being offered to the nurses, are you looking at what is being offered in Dominica vis-a-vis what is being offered out there to sort of discourage the nurses from leaving the shores of Dominica? Because I have a recent issue where someone came to me and they said to me, look, a new set of nurses graduated from All Saints University, and what seemed to have happened is that they are being told that they are being given a provincial license, and as a result of that, they are making noise. They're saying, look, we have gone through the process, we have gone through the entire process, etc., and why we are given a provincial license to practice nursing practice, you have to pay the $500 fee, etc., etc., etc. And that seemed to be a major issue. In fact, I know of one of them who has decided that, you know what, I'm leaving. You train the person, and here it is now, they are gone. Another shortage, a shortage, a shortage.
Thank you. Can we take one more and then we'll answer?
You come back again.
I'm not sure. Just to mention that we're told that we haven't until 11 o'clock. Yeah, so we have about 10-15 minutes to go through. About the pay, I can just say, yes, the board is going to do a comprehensive review of compensation packages. So that would be allowances, salaries, and any comprehensive review, you take a look at what others are doing, you look at the wider economy, you look at GDP, you look at a lot of things. So it has to be a professional study, where I can tell you, yes, the board is committed to doing that. We have mentioned that. The issue of nursing, attrition, nursing leaving, I'm sure we can continue to talk about that for a long time. But nurses will leave. That's just a fact of life. Countries like the Philippines train people just knowing that they're going to go. Many of them end up in the US because when you consider, we all have family and friends of that side, what is paid elsewhere, we'll never be able to match. But as I mentioned in the introductory remarks, we have to look at reward systems. Many years ago when I studied the health ministry, it wasn't just pay. People were also looking about recognition, comfort, support services. Like we know, for example, some nurses, and I keep saying some, there are some practices that cause the absenteeism. But we also know if you had, for example, support facilities like daycare or some arrangements like this, especially for night duty, we may see reductions in certain areas. So this has to be looked at. Also, just to go back to our freelance journalists who mentioned earlier about private practice, the conditions I referred to earlier, they were not conditions set by the board. These were conditions that were set while these doctors and others worked for the Ministry of Health. And what I can tell you, we have not changed anything. But some things will change. And we make no apologies about that. Because it is precisely because there was a dominance in private practice at the public hospital that we hear our people complain a lot about, that you're getting public services and public patients taking the back seat. We are saying in the public hospital, the gift made by China wasn't made primarily for private practice. It was made primarily to ensure that the Dominican public gets priority. So we haven't changed any conditions. And so because of that, and the controversy you heard recently, Dr. James mentioned it, everybody signed in quick time. Because once they knew the truth, that there had been no decision, they signed. But what we were saying, and what you may or may not have heard, is that you cannot continue to practice exposing the hospital authority and the government to lawsuits. And there have been some in the past. Some have been settled privately without having a contract, without being employed by the government. Because we are talking about situations that can be either life or death. So we offer a contract, and if you refuse to sign the contract, then on what basis are you working? And who's giving coverage to you? And that's all we are saying. Here is a contract. What we have done, which is different, is we have said we are going to move the hospital in a direction where people must be accountable. So if you're a specialist medical officer, you should be doing ward rounds. You should be training interns and younger doctors. You should be doing a certain number of clinics, outpatient clinics, and you shouldn't be coming to an outpatient clinic at 12 o'clock when people are sitting there from 8 o'clock. These are the realities we have encountered, and we are saying we have to do better than that. You come from La Plaine, one of my favorite villages, to get to see a specialist. You would have left home at 6 o'clock. You arrive there, maybe you're 70 years old, maybe you're 80. Why should you wait for 5 hours before the consultant begins the clinic? We're saying that has to stop, because you must account to the authority and to the government and people of Dominica, because you're paid to deliver services. And we all know it. It's been happening. And we're saying that cannot continue, because the thing must be performance driven and you must be accountable for your actions. That's it, Dr. James. Give us the last one.
Let's start with the last one first. The question of the provisional license. How it works is that you go to the State College or All Saints, and you finish what is called a BSN in nursing. You apply to the Nursing Council, and you're given what is called a provisional license. And what a provisional license allows you to do is come to the hospital and work under supervision. The only time you become a registered nurse is when you sit what is called a regional exam. And once you pass the regional exam, then you have full registration. So what we've been doing is that rather than have our BSN nurses, or we call it graduate nurses, remain at home, we bring them on as what we call nurse interns, so they could begin to get a level of orientation into the practice while preparing themselves to do their regional exams. Once they pass the regional exams, then they apply to the council and they get full registration. This is a practice that existed before. When we came on board, it had ceased to continue, and our board has now reinstated. Because we're saying it doesn't make sense you have these nurses sitting down at home 6, 7, 8 months, de-skilling, when they could come to the hospital, earn, not at the level of an RN, because they're not an RN yet, but earn enough, practice the trade, and therefore prepare themselves for the regional exam. The issue of complaints, yes, when we've launched the public invite to lodge a complaints to the quality department, and we've seen an increase in the number of patients presented. As a matter of fact, very shortly we will go into the board with a proposal to seek to expand that department, because based on our protocols, all complaints must be acknowledged within 5 working days, and they must be closed out within 20 working days. We can't possibly do it with 1 or 2 persons, so we have to actually set up a department or expand the department to address complaints, incidents reporting, and this other area of the patient care experience is now becoming a new feature of that particular department. And in terms of vaccination coverage, we haven't gone beyond, all told, more than 55% of our staff being vaccinated. We still have the same apathy of selected categories of staff for whatever reason. We haven't gone beyond that 55% margin. Certain categories are much higher. Doctors, for instance, are about 65%. Nurses are very, very low, about 45%. Orderlies and wardies in the mid-50s. But all told, around 55% staff are vaccinated. Revenue generation. Perhaps the most significant challenge we'll face going forward, because our board is going to have to spend enough time in evolving a new financing model for public health systems. New technologies bring with it new costs. I can tell you our imaging department, preventive maintenance contracts there alone is $450,000 a year. Yes. Yes. 450,000 US dollars a year. If we don't maintain it, the plant shuts down. We cannot do it, therefore, on the model that we now have. So our board is going to be looking at areas such as philanthropy, strengthening our billings and collections mechanisms. We're going to have to look at the SRO, the statutory rules order. Our director, Dr. Robinson, raised the point. This is a public facility. We cannot increase the fees at the hospital unless we make the recommendations to the minister or to cabinet and cabinet approves it. By law, we're duty bound to operate under this statutory rules order. But I will tell you the statutory rules order is outdated. It's over a decade and a half old. So you'll find a medication that we buy for maybe to treating diabetes might be, say, $15. On the SRO, it is $2. So you understand the difference. You can't be buying at 15 and getting reimbursement from patients at $2. So we've got to find another way in which we could index the cost of drugs that doesn't make it out of pocket. Some of us have considered full cost plus 10% or 2% or 3%. At least we'll be able to recover enough money to be able to replenish. But certainly the way the landscape is with respect to health financing is going to create some problems for us, and that is one of the areas our board will attend to make sure we could put a model in place that will allow us to sustain the plant that we now have here at the hospital. The question of decentralization of services. We have to be careful when we speak to it, because when you decentralize services, in fact, what you're trying to do is expand access. But you could expand access and then you have proper transportation networks. Or you could expand access and you don't have nurses and doctors to run the facility. So you could actually violate the principle of access by not having those facilities in place. We have looked at, in the case of dialysis, the geographic stratification or location of our patients. And I can tell you, based on where patients are located, we believe setting up the dialysis, an expanded dialysis service in Marigot will certainly allow us to be able to manage what we have and expand access. Give me a quick point. If you have somebody who is living in Portsmouth, because you raised the issue with Portsmouth, but work in Roseau, it becomes very difficult. It becomes easier, I should say, for that patient to go to Roseau, get dialyzed, and then come into Roseau to work. So it is not as easy to say, put a facility down at Roseau, because once you expand it, you're talking about all the attendant recurrent costs. Based on my information, these 31 patients that we now manage, based on where they're located, Portsmouth would be less of an issue with respect to the decentralization that you speak to. And so therefore, we don't feel at this point in time we'll decentralize. However, when Portsmouth kicks in, we'll certainly look at the question of rationalizing services. So for example, if our medical wards are filled here, we can then move some of these patients down to Portsmouth as a decanting facility to free up beds here. So the compendium of facilities we have that forms the Dominica Hospital Authority present for us a number of options and opportunities that we haven't even yet explored, but that exist with us now, and should the need arise, we can then move in that facility. Yeah.
So I'm going to address the bill situation here, but I want to make a comment from a news site and just ask that last one.
Yeah.
Yes, well, this is saying there, tell Carlisle, ask why 20 plus nurses leaving, but yet nurses are short-term contracts, especially the NAs. Too little staff, one RN, one NA on shift, 20 plus patients. Somebody answer that?
Yeah. Yeah, so but I was just hoping to end up with a thank you, so I don't know. So come before me.
Yes.
I was going to do the thing. Yeah, because I have to go back to master control. Yeah. Yeah. So we can say to the nurse, we are constantly looking at our numbers. It will be very easy to say we need 500 nurses, I'm sure, but we need to have the resources to pay, and it's not just paying salaries, there are other things. What we can say to the nurses, all of these issues are on the table, and we will continue to look at it. In the new arrangement, there will be some greater demand because our people ask for greater privacy. We're going to give them, we'll move from an open ward of 20 beds or 24 beds. It will be 6 and 4 and 2, as you see, but that calls for greater resources. So just be assured we'll continue to look at all of these issues. Before going back, and so Stephen, because you have to go back to master control, I just want to say thank you very much to the media for coming and for coming in such large numbers. Thank you to our chairperson who was not on Zoom but has been listening via MO News, not intending to promote MO above anybody else. Our board member John Bellott has been there on Zoom. So to say thank you to Dr. James, Dr. Blanc, who was also on Zoom listening and being ready if her intervention was required, to our senior staff who are here, of course my fellow director and friend, Cyril Robinson, Dr. James, again, thanks for a comprehensive report. There is a secretary behind the scenes, Ms. Felix, who had to help put things together. And of course, I wouldn't forget you, Stephen D. Thank you so much for arranging everything. When I last checked, I was told there were refreshments for the media. I hope they have arrived. So thanks again to everyone. Thanks very much for coming. And I hope our public is better informed from this intervention. And I can promise you, perhaps within another few months, we will have another such arrangement because very soon we expect to hear the announcement for the opening of the inpatient building. So in time, we will be back with you. Thanks again.
The Dominica China Friendship Hospital, we have come to the end of this news conference organized by the Dominica Hospitals Authority. Of course, and as we heard from board member, that is Dr. Cyril Robinson, we also heard from the CEO, Dr. Dexter James, and we also heard from the deputy chairman of the Dominica Hospitals Authority, His Excellency Elwood Williams. And so on behalf of our technicians, we want to say a big thank you to all many listeners, our technicians, Aaron, Wiltshire, and also Denzel Shellingford and Chief Tech, Dean Thomas, Stephen Dangleman taking you back to Master Control on TBS Radio.